Seated. My name is Esperanza, the Managing Director at the Latino Media Collaborative. And thank you for joining this month's Diálogo, A Tu Salud, Prevention and Early Detection, Breaking Stigmas and Embracing Wellness Across Generations. If this is your first time joining the conversation, today's event is part of a series launched by the Latino Media Collaborative and our flagship news initiative, Galo News. Our mission at LMC is to leverage the power of Latino and community news media to impact policy, change narratives, and promote civic engagement while supporting advancement of the sector through capacity building, research, and advocacy. And today's Diálogo is meant to foster an open dialogue within our community on the most pressing issues. And we hope our conversation will educate, activate, and also entertain. I wanted to take a quick moment to acknowledge some of our special guests. I believe, well, actually, they're still on their way, in addition to our panelists and speakers today, which Martin will introduce in a little bit. Without further delay, I'm going to officially hand it off to Arturo Carmona, our president at the Latino Media Collaborative.
Thank you, Esperanza. My name is Arturo Carmona. I'm the president of the Latino Media Collaborative and publisher of Galo News. I also serve as board member of the Adventist White Memorial Foundation Board, and it's a distinct pleasure to be here with you all and have made this event possible. The Latino Media Collaborative is a leading advocate for Latino media and journalism in California, but growing into other states around the Southwest. Over the last few years, we have been able to secure tens of millions of dollars for Latino media and journalism to empower our storytelling capability, particularly in Latino-led or focused outlets. From ensuring that state government agencies are being transparent and equitable in how ad and marketing dollars are spent, to ensuring that state agencies are spending resources equitably, inclusive of Latino and ethnic and community media, the LMC has raked key legislative victories that benefit communities most in need. And a little over a year ago, we launched our flagship news initiative called Galo News, an English outlet focused on Latino communities. And we started as an outlet with a vision of building a news operation anchored on a simple motto: our community, our narrative, our history. And we are happy to report that the community has been very responsive and is following our work. And we are on a course to meet our audience and engagement benchmarks and quickly approaching our goal of building a dedicated audience of 250,000 Latinos. And we are doing this by investing in a community of creatives and reporters as well as partners. We are now producing over 40 stories a week, which is no easy feat. And we're doing this with an amazing team of reporters and includes creatives and cartoonists and comedians like Lalo Alcaraz and Al Madrigal and many other folks that we have here with us today. We are now producing, and we have been able to secure some key partnerships with outlets like LAist, the LA Blade, an LGBTQ partnership, La Opinión, LA TV, San Fernando Sun, Cal Matters, and several others. At the end of the day, we remain centered on our mission and the critical issues impacting our community. And there's no issue more central to our community than health and wellness. As we will hear from expert panelists through our program today, health is at the center of everything we do, particularly the focus of the Latino Media Collaborative and Galo News. A significant portion of our content is dedicated to this issue, so we are so happy to have this convening today. And without further ado, I'm gonna pass it over to the president of Adventist White Memorial, John Raful, who will give us some opening remarks.
Hello, everyone. Well, welcome to White Memorial. Thank you for being here. And I'm looking forward to our event today featuring the Diálogo series. Did I say that, Juan? Okay, see, I can speak Spanish. Anyway, I want to thank Gallo News for including us in their signature series. I want to thank our partners, AltaMed, Walmart, and the Latino Medical Collaborative for supporting this event in order to alleviate that fear of people coming forward and seeking help when they have a diagnosis such as cancer. That's so important for us here. You'll hear from our nurse practitioner, Eva Myers. I see her sitting there, that she runs the cancer center for us here. Also, you'll hear from Dr. Hector Flores as well. He'll be a very good speaker. I think I'm looking forward to hear him talk, and several others. He runs our residency program in family practice. So he's a teacher, professor, and a physician at the same time. And we'll follow the panel discussion with several other people as well. There'll be panel discussion. I'll have some questions and answers after that. White Memorial Medical Center, we've been here in this community for 111 years. So that's incredible to be here for so long, serving the Boyle Heights community and the East Los Angeles community. And there's nothing more important to us to make sure that our community gets the information they need and be able to take care of themselves. So this is important to spread the word, and there's not enough of these events that we could have to spread the news out there, to just tell people, you don't need to be ashamed if you have a diagnosis of cancer. You need to seek help. You need to come forward. You need to ask for help, ask for physicians, ask for the hospital, show up to do that. A lot of people sometimes are embarrassed and they don't want to tell anybody, they don't want to do anything about it. So our goal tonight is to address these barriers that we have in our community that holds people back from asking for help and seeking, help for their cancer diagnoses. And we will, you all know about our, Cecilia de la Hoya Cancer Center that was supported by Oscar de la Hoya. He's a big supporter of that, and we named the center after him because he's made several generous donations to the hospital in that regard. So he has an interest as well in promoting health and wellness when it comes to cancer. Our charitable foundation, as well as our Community Resource Center, both work together to make sure that our patients have access to the most recent information and be able to help them navigate through our system to get the help that they need here at the hospital. And also, language is always a barrier, right? And you walk into a lot of hospitals, everybody speaks English, nobody speaks Spanish. Well, I tell you, we made a concerted effort for the last 20 years here at White Memorial to make sure that we hire and retain Hispanic nurses that are bilingual. We do that through a relationship. We have TeleQ, where we actually fund the program, and we give scholarships to Hispanic nurses or Hispanic folks that want to go into the nursing field because we believe that you gotta deliver culturally sensitive care. You can't treat a patient if you can't communicate with them, right? So you have to be able to communicate with them if you want to treat them and give them, the right medicines and the right treatment. So language is essential. And I tell you, when we started 20 years ago, we had less than 9% of our nurses are Hispanic speaking. Today, we have over 38% of our nurses speak Spanish. So we're very proud of that progress that we made in that regard. So with that, again, I want to say thank you for making the effort. Thank you for being here. I look forward to a very engaging program and panel discussion today. Thank you.
Hi, everybody. I'm Martin Albornoz. I'm GM of Gallo News, and I actually want to introduce our next speaker, Michelle, who is taking a photo as we speak. She's a consummate journalist. It's Michelle Zacarias, and she's going to tell you a little bit about her experience with cancer and the stories that she's writing for Gallo News, which you can definitely read. There's one that's up today, which is really amazing. So, Michelle.
I'm a little short. Hi, everyone. Thank you for being here. My name is Michelle Zacarias. I'm a reporter for Gallo News and a UC Berkeley local news fellow under the Latino Media Collaborative. This last June, I was diagnosed with stage 3 colorectal cancer, and as I was approaching the 1-year mark of my journalism fellowship, despite being employed and having full access to health insurance, it took over 9 months to diagnose me. This isn't my first encounter with cancer. I'm also a childhood bone cancer survivor and had been in remission for almost 25 years when I received my recent diagnosis. As a journalist, I feel compelled to share my story and address these critical issues around early detection, public health, especially as a queer Latina woman. In October of 2023, I began to experience a mix of distressing symptoms, including diarrhea, bloating, increased gas, alterations to my stool, all of which are things that are really uncomfortable and gross to talk about in any household, but especially in a Latino household. And it wasn't until I lost 30 pounds in a span of 4 months that the severity of the situation really set in for me. It took over 3 months for me to see a GI specialist and an additional 2 months to schedule a colonoscopy, all while my situation grew increasingly more dire. In June of 2023, it was confirmed that I had a malignant tumor, which was so large at that point that it practically blocked the entirety of my colon. In August, I underwent surgery to remove this cancerous tumor, and the procedure was successful thanks to my all-Latino surgical team. Having the faces of people who looked like me in the operating room advocating on my behalf was so important to me in those vulnerable moments. If you followed the work of our incredible reporters at Galo News, you will find a number of articles written on this subject, including one that's authored by my esteemed colleague Amarani Hernandez, who's over here in the middle row, on why it matters that only 6% of physicians are Latinos in the US. Her coverage underscores the vital importance of cultural representation in healthcare, and for many patients, encountering a medical team that reflects our own backgrounds fosters trust and understanding, and this shared cultural connection can break down language barriers, alleviate misunderstandings. It can create an environment where patients feel more comfortable discussing their concerns. Ultimately, these elements are essential for delivering effective and compassionate medical care. Last month, I began chemotherapy to treat the remaining cancer cells in my lymph nodes, and I also launched my cancer-focused column, Sin Pena, a Latina's experience in navigating colorectal cancer, which you can also read on the Galo News website. Sharing my cancer journey is both a personal decision and one that I hope will lead to better understanding and open dialogue amongst community members. The research is clear. Seeking early medical intervention is crucial and it's necessary. And Latinos are consistently faced with socioeconomic barriers in healthcare, especially those who lack access to public resources because of their immigration status. In January of 2024, California became the first state to offer health insurance to all eligible undocumented adults. And Galo News reporter Brenda Verano, who's over here with the camera, highlights this landmark achievement in her story, written in collaboration with USC's 2023 Health Equity Fellowship. She emphasizes, however, that amongst the immigrants who are eligible for health coverage, many remain uninsured because of a range of enrollment barriers, including confusion about eligibility processes, difficulty in navigating enrollment, language, and literacy challenges. I know a little bit about this because my mother was an undocumented immigrant from Zacatecas when she was 22 years old when I was diagnosed with bone cancer, and she was tasked with this responsibility of my well-being and livelihood at a very early age. She had to navigate not only a new language, but also the complex medical terminology necessary to secure life-saving treatment options for me. Early detection necessitates dismantling barriers at every level of healthcare access. Whether it's authorizing a referral, locating a specialist, or simply scheduling a routine checkup, people should not have to endure months of delays to have their medical needs addressed. Streamlining these processes is crucial, and it begins with the greater access and cultural competency in the medical field, but we must also ensure that the information is readily available and that providers are responsive and that patients feel empowered to advocate for themselves. There is no shame, as it was just said, there's no shame in seeking out help for health-related issues, right? Sin pena. But my story is sadly not uncommon. especially amongst poor and working class Latinos throughout Southern California. I have been privileged enough to access the treatment needed for colorectal cancer. However, the challenges that I face have also inspired me to advocate for those who may not be as fortunate. By fostering a more inclusive and efficient healthcare system, we can promote early detection, ultimately improve health outcomes for community members of all identities and social statuses. And so I challenge everybody here in this room, every healthcare professional, every decision maker, to take action and drive the changes that are needed in our policies. Your influence can make a profound difference in ensuring that everyone has access to the care that they deserve. Thank you.
And thank you, Michelle. That was moving. And shameless plug, you have to go and read her column, Sin Pena, on Calon News. And then also, we're filming this, and so this is going to be online, and we're not live streaming, but we're going to have the video online. So if you want to share the link, please do so. We'll definitely have that available on the website. So I wanted to take a few moments before we bring up the panelists just to thank everybody who's here. Thank you all for making it. I want to thank our sponsors, everyone listed here. So Adventist Health, White Memorial, thank you for everything you've done helping me set up. Actually, thank you, John Raful, Juan de la Cruz, Kathy Huang, Tony Hernandez, Jim Dover, Ignacio. You guys have been great in helping us do this. I also want to thank AltaMed. Christina, thank you so much for your support, and thank you for providing a panelist, which we'll introduce shortly. I want to thank Walmart, and Javier, thank you so much for your support. And then also North Star Alliances, who were very helpful in setting everything up here, so thank you guys. So let me give a quick kind of background of why we're doing this and why this is such an important thing. So according to the CDC, cancer and cardiovascular diseases are the #1 and 2 leading causes of death for Latinos, Latinas, and the Latinx community. And we have a higher likelihood of dying from certain kinds of cancer than the general population. We're less likely to be diagnosed with the most common cancers like lung, colorectal, breast, and prostate. We're also more likely to develop cancer in the liver, stomach, and cervix. There are many reasons for the disparity, including institutional racism, poverty, a lack of access to health care and health insurance, a lack of health literacy, and a lack of health care workers who speak and understand Spanish. That being said, I do want to say we're doing this in English, but during the Q&A, if you have questions in Spanish, we can speak Spanish, we can translate, and so please, if you have, si tienen preguntas en español, pueden hacer las preguntas al final del el panel discussion. So I'm going to be a little pocho in my mixing there, but so these are some of the questions we will address. The structural issues that keep Latinos from early detection. How do we educate our community to get checked out sooner and more often? How do we educate our community to advocate for themselves, especially when there might be a history of cancer? And how do we, as a community, become more open to discussing diseases so that we can improve our survival rate? Sin Pena, I love the name of that. You know, we have to have a lack of you know, we need to be open as a community when we discuss these issues. This topic is vitally important to our community and to some of us personally. You've heard Michelle's amazing story of resilience and perseverance. Let's give her another round of applause. And she's still working. She's actually... So I wanted to briefly share my story. I was diagnosed with stage 3 colon cancer almost 5 years ago. Yesterday, I had my 3rd colonoscopy, and I'm happy to report that the results were good. I see my oncologist every 3 months. I get twice yearly MRIs and CTs, and I won't need another colonoscopy now for 5 years, so I'm kind of moving along in a good direction. It seems like such a long time ago that I went through a month of radiation, 8 rounds of chemo, multiple surgeries, but because of the amazing work of my doctors, I'm here today. I was diagnosed at 48. And it was only after 6 months of visiting doctors, complaining about symptoms that weren't taken seriously. The old guidelines of getting a colonoscopy at 50 have now changed because of the epidemic of younger people getting colon cancer and other cancers. But even that is a struggle to get, even if you're complaining and you're going in, it's hard to get that cancer, the colonoscopy approved by your insurance. Unless you have a history of cancer in your family, people are gonna question, why do you need this colonoscopy? So it is important that even if you have symptoms, that you get checked out, and if you're anywhere near 50, go get a colonoscopy. If that's the one thing that I can just get to everybody, just go and do that if you haven't already. I know, Arturo, you just did. We're laying it all, sin pena. It's all out there. I would take 1,000 colonoscopies over a year of chemo and surgery, so get to it early. It's not hard. The one thing I do want to implore on everyone here today is to advocate for yourself. Advocate for your spouse, your children, your parents. Advocate for your community. We don't want to put one more life at risk because they didn't detect cancer early. And so with that, let me introduce our panel. And come on up when I call you. So Dr. Hector Flores, come on up. I think most of you know Dr. Flores. He's chairman of the Adventist Health White Memorial Department of Family Medicine. And I think an amazing speaker, and we'll be up shortly. Dr. Faustina Nevarez, medical director. Medical director for women's health at AltaMed Health Services. Come on up. We also have Eva Myers, nurse practitioner, PhD. And she is at the Adventist Health White Memorial Cecilia Gonzalez de la Hoya Cancer Center. And last but not least, Diana Estrada Stolpe. And she's an MSS Pharmacy Clinical Services Manager with Walmart. All right, thank you all. Thank you all for being here.
Thank you.
All right, so let me start by letting you each introduce yourselves briefly and tell us a little bit about what you do and what your role is at your organization. And do you want to start? Diana, why don't we start with you?
All right, can you hear me okay? All right, so I am a regional clinical pharmacist for Walmart. I've been with Walmart for about 18 years. My education is I obtained a Bachelor's of Science at UCSD in biochemistry and cell biology, and I got a master's in forensic sciences. As you can tell, I like the sciences. And then I obtained my doctorate degree at the University of California, San Francisco in pharmacy. So since then, I have been doing all kinds of pharmacy work. I have worked for pharmaceutical companies. I have worked for retail companies. I have worked for teaching, and I interact quite a bit with the community on a daily basis for the last 18 years.
Thank you. Eva.
Thank you. My name is Eva Myers, family nurse practitioner specializing in oncology. I'm so honored to be here at the Adventist Health White Memorial for the last 12 years in the Cecilia Gonzalez de la Hoya Cancer Center. In honor of Oscar's mother, who passed away from breast cancer in her 30s. And we're just so happy to be able to provide high quality cancer care to this community. I've been in nursing a long time. The new focus is medical breast, comprehensive medical breast, where we can one-stop services for everything breast. So we'll talk some more about that, I'm sure, as we progress through, and happy to be here tonight.
Great, thank you, Eva. And Dr. Nevarez.
Thank you. My name is Faustina Nevarez. I'm the medical director for women's health at AltaMed for the last 5 years. The 40 years before that, I was the chief of service at the tertiary care center for the Kaiser Permanente. I graduated from the University of San Francisco. I feel very honored to have been able to put together an OBGYN department, and I love working with this particular hospital. I don't think AltaMed can do it without you. I enjoy the conversations I've had with John Rafful. I never pronounce your name, I'm sorry. But enjoyed working with this organization. It's absolutely imperative. And the most important thing, a friend of Hector's. We've known each other for 45 years, 50 years.
Amazing. That's great.
For a long time.
We were 2 years old at the time.
Dr. Flores.
Buenas noches, good evening. So I'm Hector Flores. I'm a family physician. I've been here at White Memorial 36 years.
Wow.
And it's been a lot of fun. My colleagues and I founded the Family Medicine Residency Program here at White Memorial in partnership with the hospital. And we started a private practice in this community. And our goal was to begin to populate the needs of the community with physicians and other health professionals. When we started, the ratio of primary care doctors to the community was worse than third world countries here in East Los Angeles. And since we've been here, we've graduated 270 young physicians. 65% of them are underrepresented in medicine, and 70% have stayed in this local community to serve the underserved. And a big part of my practice, besides being a family doctor, is to advocate for the community and to increase the number of Latino physicians in California. That 6% is not enough is very clear in our mind. And secondly, to change medical education so that even non-Latino physicians learn how to take care of our population, and in turn that we learn how to take care of all people who live in California. So I'm looking forward to the conversation. Thank you very much.
Thank you. And as a kid, I had a surgery here. And my mom also had a surgery here, so we probably saw you back then, a few years back. So let me start with Eva. It is Breast Cancer Awareness Month, and so maybe you can spend a little bit more time talking about what you guys are doing here at the De La Hoya Cancer Center, some of the future plans, and how you're becoming basically a one-stop shop so that people can come in, get diagnosed, get radiation, get treatment, and find a cure here at one place.
Thank you. The focus certainly with any kind of cancer is early detection. With breast cancer, we're all at risk because we have breast tissue, and that includes men as well. Maybe not as high a risk as female population, but we're all at risk. And if it's going to happen to you or going to happen to me, let's find it early when it's easy to treat, and that makes such a big difference. The treatment process and the outcomes are so much different when we're able to find an early stage cancer versus it's already well advanced by the time we discover and begin treatment. So my expertise for the last 10 years has been the public health program here in California, Every Woman Counts, where we were out looking for eligible women, uninsured, undocumented, low income with no insurance, and be able to offer free breast and cervical cancer screening for that population. And we did a good job of it. We were one of the few hospital-based Every Woman Counts providers here in Los Angeles County, and we were out doing, I come from a background of mobile cancer screenings. I mean, you park a mobile mammogram van at a Catholic parish here in Los Angeles County on a Sunday morning, and you have a continual stream of women from 6 o'clock in the morning till 4 o'clock in the afternoon. And most of them at that time were eligible for the public health program and for free mammograms if we were able to provide the service in a convenient, accessible way. Of course, the landscape has changed by now significantly here in California because everybody has Medi-Cal insurance. The challenges continue though because it's all signed over to managed care Medi-Cal. Instead of direct services, get a mammogram today, do a biopsy next week, now we have to get authorizations through the managed care plans. And there's so many learning, and we're identifying so many health disparities. One big part of that, for instance, in California, where the law says that every woman that needs a breast mastectomy is required to be offered reconstruction services. Problem with that is, under state of California Medi-Cal, here in Los Angeles County, there's almost like 0 plastic surgeons that are signed up and able to bill the state of California Medi-Cal for that service. We're too close to Hollywood. All the plastic surgeons are overwhelmed and busy and making good money, making people beautiful, and augmentation and all the fun things that nobody is even signed up to bill state of California Medi-Cal for breast reconstruction surgery. Recently with AltaMed, we looked at their list. They had 35 plastic surgeons contracted with AltaMed primary care clinics, and as we started checking with them, 0, I think, were able to provide breast reconstruction surgery. So the plastic surgeons are contracted, but they're not for breast reconstruction services. So that's one example of problems we have to solve and how we have to get better with this kind of thing. It's amazing to me how many women, even today, show up in the emergency room with breast pain or breast lump or breast infection. And sometimes they'll even say, I called my primary care doctor and I told them I had a new red hot breast lump. And they said, well, I can't get in to see you under managed care Medi-Cal for another 6 weeks. Why don't you go to the emergency room? So they follow the directions and go to the emergency room. The emergency room does very little, except maybe offer some pain medication. But at least our emergency room doctors know about our Cecilia Gonzalez Comprehensive Breast Clinic and know to send those patients directly into the cancer center. So hopefully within 2 or 3 days. And then the goal is to be able to at least be able to navigate them through the healthcare delivery system. The first thing is to find out if this is cancer or not cancer. And then the second thing, of course, once it is diagnosed as a breast cancer, to treat it, diagnose it, and treat it in a timely way. It makes such a big difference when the medical team know each other, when they are used to working together, when they're able to talk about live cancer cases in a tumor board setting twice a month, which is sponsored by our cancer center because we are accredited through the American College of Surgeons, and we're required to do live consultations of breast cases where physicians can get their peer opinion about the best way to handle this unique or challenging case. It makes such a big difference. And of course, all the high quality documentation required to run an imaging center, where a lot of the local independent radiology imaging centers in Los Angeles County don't go through this same scrutiny to make sure we have high quality care. So that's a big part of what we do, is managing and navigating breast symptoms to find out, first of all, what it is it malignant or not malignant, and then be able to treat it all in one place in a timely, convenient way with a quality medical team equal to any comprehensive cancer center, equal to any academic institution across the street at Keck USC or UCLA or Cedars-Sinai. We have the exact same equipment here because of the commitment of our administration to have high quality commitment and high quality physicians here on the campus. So it's an honor to be part of that team and to just help women through that very challenging process.
Yeah, thank you so much, Eva. And you do have even some of the doctors from City of Hope.
We
have
do.
a new one that's starting here, so that's amazing. I was going to ask Dr. Nevarez, can you talk a little bit, Eva kind of touched a little bit on some of the symptoms and things that people go to emergency rooms. Can you maybe talk a little bit about what you see as some women issues, symptoms that they could see that maybe would point them to going to a cancer center or talking to their doctor about possible cancer or other, heart disease, diabetes, things like that?
Well, thank you. Gave me a blank slate.
There you
I
go.
can do that. Yes, first of all, I want to thank Eva because she has been a godsend. We work very closely together. I think AltaMed does a fabulous screening program. They have approximately almost 40,000 people to screen based on the screening criteria. And now their criteria is to start at age 40 because the symptoms, the breast lumps, all those are well fine. But if you can get that mammogram early detection, then your survival rates are like 90%. So that is the goal, 90% survival rate. But you're going to have to go with mammography. And it's kind of interesting how if it's available, we can fit you in. And yet, it's scary to have a mammogram. It's scary to find out that you have cancer. And it's interesting, the education that we've had to put out, the outreach, we call every one of these people over to come in and answer some of their fears. And then there's also the logistics, coming in, getting away from work, making sure that you have childcare. It's all those things that keep women from going there. But yes, of course, a lump, pain, blood coming from the nipple, these are all advanced. There is a very aggressive cancer, it's called the triple negative in the Latino and African American community that is growing, where you're going to see these symptoms. It's triple negative because the receptors are negative. This is all, just came out this month. the receptors are negative for estrogen, progesterone, and human HERS, HERS. And so because the receptors are negative, you can't give them receptor therapy. So it's chemotherapy, immunotherapy, and a much worse outcome. So those are people, our populations are affected where we're seeing more of this cancer, and it's growing. But overall, the screening, the mundane screening we do every 2 years, starting at age 40, is where we go. But I'll tell you, when it comes to, I have to tell you this story. Are we working on cervical cancer? Are you sure? Okay. As I had told you, I had been at Kaiser for 40 years. And, you know, it's a slightly different population because everybody can pretty much walk through the door with a very low copay, and they do. But whenever we have new patients with cervical cancer, I always worry because it's the women who have not been screened that worries me so much, because that's where you find the advanced cancers. Now, cervical cancer is practically covered. It's like we've conquered it. HPV vaccine at 11 years old? Yes, at 11. Why so young? They're not sexually active. I think Martin asked me that question.
Yes.
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 It's because that's when the immunity is the best for the children. And if you give the immunity at 11, they're going to be immune for life. If you wait until they're 20 or after they're married, it doesn't take so well. You want to do it at 11. Australia practically wiped out all cervical cancer by giving these vaccines. We can do that. But when I came out of Kaiser, one of the first patients I met was a 32-year-old with 4 young children. And I came across her chart, and she'd been referred out, kind of the same thing we see with breast. Ping-ponged around, never got her colposcopy. A year or 2 went by. I finally called, and I said, why haven't you come in? No, doctora, it's $400. I can't afford $400, and what if it's negative? Well, we knew her PAP was wrong, was bad. We knew her HPV screening was bad. We really had a good suspicion that she had cervical cancer. By the time she came in, and what we did, one of the things we did is we put the colposcopes in the offices. So it's a regular visit. We don't have to refer out anymore. We also did leaps. We can do the leap things in the office, so we don't have to send them to the hospital. And all these things, bringing the care to the office where the woman can walk in, makes a difference. It was very sad because she had stage 4. And so then she had to be referred to an oncologist, and of course, these young children are now orphaned because it's been that long. But it's almost, I can count on my hand the number of women that ended up in this position. And she had lead time. We could have taken care of her. But there wasn't a colposcope around, and there wasn't a leap machine. So that's one of the things we've done with AltaMed is we put colposcopes in all the offices and gynecologists so they can use them.
Well, so we're going to talk a little bit more about disparity, and I think, Dr. Flores, you can definitely help me with the conversation on insurance and Medi-Cal. But I also wanted to talk a little bit of some of the cultural issues that we have that keep us. And the reason I brought that up with HPV is that I have 2 daughters. They're now in college, but when they were 12, 13, their pediatrician said they should get the HPV vaccine. And instantly, as a father, you're like, what, why? You know, it didn't make sense. But those are some of the issues I think that we have culturally that we kind of, you know, we're that doesn't sound right. And so, Diana, I'm going to ask you, you know, tell me a little bit about your experience growing up and what you've seen as you were a student, and you know some of the cultural issues that maybe you've encountered or saw.
Yes, so when I was studying undergrad, actually, I was taking a cancer course. That was one of the initial parts of my interest into science. And one of the projects that I had to do was to try to do something that would differentiate the Latino community from the regular community. One of them was how come we have less, attendance to just regular visits to the doctor, and why would we have less, pap smears and that kind of stuff. And one of the things that I came across at the time, and we're talking about like late 90s when I was doing this, and I think it still holds true, is, at least in my experience and what I've learned, was in a lot of the Latinx community, we tend to be a little more modest, and therefore the idea of having to go do a physical exam, having the physician, whether it be male or female, touch our breasts to check, or touch, put your legs out, right, to do a pap smear, it's uncomfortable. And so because of that, a lot of people tend to just not want to do the test. And the danger with that is it may be slightly uncomfortable initially for them, but what they don't realize is if they don't get checked up, if they happen to have any sort of signs or cells that could potentially divide and become cancerous, their chances of survival are going to be very minimal. And what they don't realize either is that once you're getting treated, you're going to have to go through all this tests. People are going to be looking, touching, whatever it is, to try to get you cured as much as possible, right? Or to try to make your life a little bit more doable, or make a better of whatever you have left. Some of the things that I tell some of my patients is when I tell them about cancer prevention vaccines, because I deal with the general population at retail, is for when it comes to HPV, is a cancer-saving vaccine. It's not, because of sexual transmission or whatever it is. I mostly focus on cancer prevention. It can prevent you from having cancer. It can prevent your kids from having cancer later on. That'd be boys or girls as well. Usually we used to think about girls when it came to HPV for cervical cancer. Well, we know now as well that especially in men, there's a high incidence of oropharyngeal cancer, cancer of the mouth, cancer of the throat. And this vaccine is very effective. So I highly recommend, tell your people, tell your families, tell your friends, hey, don't be afraid of this vaccine. Some of them will be like, well, I'm afraid of needles. Well, guess what? This needle is a lot smaller than if you were to get sick. They're going to put big needles in your arms. That will be painful, and then you have to deal with everything else. So,
yeah, thank you, Dana. I'm going to read some data here, some statistics. The American Cancer Society recently reported some major health disparities between whites and Latinos. 28% of Latinos between the ages of 18 and 64 lack health insurance, compared to 8% of whites. When it comes to cervical cancer screening, the percentage of Latinas who get screened for cervical cancer based on the guidelines is 69%, compared to 80% for whites. Percentage of Latinos who get screened for colorectal cancer based on the guidelines is 52%, 65% for the white population. Prostate cancer, it's just over and over, 28% for Hispanic men, 38% for white men. So Dr. Flores, can you speak a little bit to the disparity, and what are some of the structural issues, and how can we address those?
Sure, thank you. So part of what Michelle Zacarias mentioned earlier, which we made history this year by covering undocumented individuals, and that's thanks to our local state senator, Maria Elena Durazo, being the champion. Obviously, others helped to promote that legislation and convince the governor to sign it. But we made history, but now that we have almost universal coverage of all Californians, including the undocumented, it's exposed the critical shortage of physicians that we have, especially in communities like this community, East Los Angeles. And that also immediately makes access a problem. When we talk to our emergency room doctors here at White Memorial, they're seeing more people coming to the emergency room newly insured with Medi-Cal, but they're saying they don't even know who their primary doctor is, or they know who that is, but to get an appointment, it's going to take 2 or 3 months to get an appointment. That's how bad the access is. And when we look at our population of Latinx, 40% of Latinx are on Medi-Cal. There's about 16 million of us. So we're talking about a big chunk of people who are covered by Medi-Cal but are having that access problem that I just described. There's another 25% that are $1 too rich for Medi-Cal, but they may not have insurance. That falls into that group you're describing, especially undocumented, because the federal government will not allow undocumented individuals who would otherwise qualify for covered California to use it. So we're going to have to come up with our own program for that. So those folks are also having access problems. Then on top of that, being covered by Medi-Cal creates a huge access problem because of the low payment of Medi-Cal. Just to give you all an example, if a doctor sees a patient with full commercial insurance and provides a service, let's say it's $200, if that same patient is covered by Medicare, they'll get about $150. But if that patient is covered by Medi-Cal, they'll get $42. So you can see how this becomes a barrier for patients because it's the payer difference that makes doctors not want to see Medi-Cal. We're very lucky that here at White Memorial, because White Memorial's tradition has been to serve this community, being faith-based, being a teaching hospital, and a private hospital attracts a high caliber of physicians. So we're very fortunate that we have over 500 physicians on the medical staff, all very well trained. But the need in the community is far greater than those 500 physicians can provide. So the disparity is the payment, which creates an access problem for patients. The second thing that I was so impressed with Michelle sharing your story, I really appreciate it, very powerful, is the other piece is that our community gets profiled. You know, just like she was profiled, you're too young to have cancer, so the doctor's not even thinking that you would have colon cancer. That is not fair to the patient. We're profiling them. We're profiling them, patients don't want to take care of themselves. Patients don't care about their health. They don't. Yes, we do, but we need to be empowered with information and empowered to be partners with the clinicians who take care of us. Because the other issue is that 30% of us are new first-generation immigrants, and we see them every day how desperate they must be to risk the lives of their children and themselves to cross the border. And then secondly, how desperate they must be when they hide because they don't feel that they're safe enough to be seen by a physician, even in an emergency room, because they're afraid of deportation. So that creates another barrier. The other part of that is coming from their home country, and I'm a first-generation immigrant, my parents is the classic immigrant story, is that they're so poor in their own country that they don't trust institutions that are supposed to help them, because many times they've been burned by those institutions. So when they come to the US, they feel like this bureaucracy is going to beat them down. And so they have trouble even envisioning themselves deserving the care that's available to them. So it's a multifaceted issue that we need to fix. And what we have found is we need to transform medical education so that these institutions, the leaders of those institutions, can respond to all of those issues and not profile the patient, not minimize their concerns, and empower them to be active participants in their health.
Great, thank you. And I actually did meet some of your volunteers, and the group of college students that you have here were just amazing. And so that's a great program that you got set up here, trying to bring in new nurses and hopefully doctors someday. Dr. Nevarez, can I have you maybe talk a little bit about the disparity, not just between, Latinos and the general population, but with women? I'm sure there's even higher issues dealing with heart disease and other critical diseases.
Yeah, historically, the people who get heart attacks were men. That's what we were taught in medical school. And guess what? It was wrong.
The profiling, right?
The profiling.
Yeah.
The profiling is wrong. Women get heart attacks just as bad as anything else. In our population, in addition to cancer, probably the biggest reason for death, or the number one cause of death, is heart disease of all kinds. And I think that we probably need to address even more basic things like nutrition and diabetes. Can't hear me? Oh my God.
Yes, it's
Okay.
better with it.
All right. Nutrition and diabetes might be something that we really have to target, because even if you took all the cancers and put them all in one bucket, certainly for women, you would still have 4 times deaths due to heart disease. So it is something where, again, we have to look upstream. Like I said, there's certain things we've had success with, but there's certain things we have a long way to go. In maternal health, boy, do we have a problem. I think you've all read all these hospitals, and God willing, this hospital will not close its labor and delivery, thank you, because the closure of labor and deliveries throughout the state is alarming. It just doesn't exist. And we just heard from our Surgeon General, in fact, just yesterday, where she says, although the worst outcomes in maternity care is in the Black community, the African American community continues to have horrible disparities. We're seeing a double increase in our own maternity, we're really increasing quickly, and hopefully we will not catch up with those disparities, but we're having issues with hypertension. We're having issues with women dying after delivery due to hypertension, cardiovascular disease, and sepsis. So our populations continue to do poorly in all kinds of situations. I'm very worried about maternity care. I'm very worried that it's totally fragmented. Our Medi-Cal patients can drop into any hospital once they are in labor, and because of the EMTALA laws, they can deliver. But the charts may or may not follow. So all those 9 months they were taken care of by their primary care or their primary OBGYN is lost. We don't know exactly. She may or may not remember her health care. I mean, she's in pain, for heaven's sake. She's got a baby that's coming. Do you think she can give a good history? And then after she delivers, if there are significant complications afterwards, she really can't describe them, and the people who are trying to take care of her will not have her chart. Now, we have laws in California that insist that we should have access to our patients' records, but because of the inconsistent use of the medical record systems in the different hospitals, it's really gotten to be quite a difficult situation, and more so for our patient population that may have gotten care one place and delivered at another.
Great, thank you. Let's focus a little bit on nutrition. We were talking about nutrition, and by the way, we have some really healthy fruit available, so some of you have already helped yourselves. I don't want everybody to just run over there, but if you want to sneak over and have a little snack, we've got plenty, and there's some aguas frescas. Or do you want to? Okay. Do you want to take it?
Okay, fine. Yeah, nutrition is a big issue as well. As you know, our communities continue to have nutrition deficits, grocery stores lack thereof. We are also pandered to with a lot of processed foods, lots of foods that have too much sugar. We do have an epidemic of diabetes, obesity, what we call metabolic syndrome, which is high blood pressure, PCOS, which includes infertility. All those things are in our community because the nutrition that we no longer have. And I have a feeling that much of our nutrition might have been better when it was just a little, a guisado with a lot of vegetables. I don't know about you guys, but that's what my mom did. Small amount of meat and a lot of vegetables, sometimes just vegetables, a good tortilla, and potato chips was just too expensive. Bologna and white bread was just too expensive. So she would just do a very basic meal. But this cross-culture that many of our patients have now are probably contributing to horrible nutrition, diabetes, heart disease, and chronic diseases.
Yeah, let me switch gears a little bit back to our conversation about some of the barriers that the Latino community, the Latinx community has in receiving medical treatment. Dr. Flores, let me start with you on this one. What are we doing to address even just the language barrier? And you kind of mentioned that a little bit. And Diane, I want you to also help me a little bit with that conversation.
Yes, so we have laws in the books since 2004 that require all health systems to provide services in the language that the patient prefers. But very few institutions are compliant with it. And so that's a problem, is that we've not enforced it. So as Dr. Nevarez was saying, we have a lot of laws in the books, but they're not enforced. And so it's hard to really get that access. Secondly is institutions that recognize that the best way to serve the patient, because the quality of care is improved the minute you can communicate with the patient. And we don't want to use family members to interpret, because many times those issues are very personal and a child should never be, interpreting for their parent, but it happens a lot, and we know that.
We've all been there.
Yeah, and we need to change that, right? We need to really enforce the law. Secondly, is that the evidence is very clear. When the patient is able to express in their own language their issues and concerns, the quality of care is much better, the outcome is much better. And then the third part of this is that we need to be able to also understand that we have a shortage of physicians, in this case talking about Latinos, a shortage of Latino physicians, and the peers that they will educate to be more proficient at taking care of our Latino community. So that's one major barrier. The other, obviously, is the coverage, that I talked about Medi-Cal being a barrier. The other is that we expect to set up our offices 9 to 5, Monday through Friday, and expect the patients to fit around our schedule rather than us being available to them when they can actually access care. In our practice, we have extended hours into the evening because we know a lot of our patients work during the day. If they take a day off to go see the doctor, they're not going to get paid for that day off. And then we may be prescribing medications and other things that are going to cost them money from their pocket. So they're in the hole the day's wages, and then on top of that, they got to pay for their health care. So for us, extended hours in the evenings and the weekends is the most convenient way that we can serve. And that's a culturally respectful way to respond to their need. The other part of that, related to that, is that the lack of coordination that Dr. Nevarez was talking about is that we need to be able to have a way to communicate. We don't have the universal EMR, electronic medical record. Certainly at Kaiser, they managed to do that for the system. And we just implemented Epic, which is a wonderful tool, a very powerful tool. And we need to get to that point where we're exchanging that information. The other part is also recognizing the patient's hesitation because they may be coming from that mixed immigration status family, and they're afraid that if they come get care, they may be exposing one of their family members to deportation. So there's a lot of those barriers that still exist, and we need to figure out how to begin to prioritize how to overcome them one by one.
Great, thank you. And Diana, as a pharmacist, you're on the front line of seeing patients. You get to see them early on. How do you offer preventative and educational services in your profession, in your line of work?
So Walmart has about 4,600 pharmacies nationwide, and there's several activities or events that we set up, typically on a quarterly basis, multiple times during the year. And we do what we call the Walmart Wellness Day events. So these events are usually 4 hours or so, and they're open to the public. They're free. We have pharmacists, technicians set up a specific area in the store, typically where people come and they're able to, coming into the store, not before, not at the exit because by then they're ready to go home. But we basically just offer free screenings. We offer free screenings on blood pressure, on BMI, body mass index, on cholesterol, on blood sugar levels. As we know, diabetes impacts the Latinx community heavily. And so little services like that goes a long ways because a lot of people may not have insurance. Those that do have insurance, they won't use it. They won't go to the doctor. And even those that are on therapy, they think that they're doing okay until we check them and they realize, oh, wait, I'm not doing so well. I've had patients before, they said, yeah, I'm on blood pressure medication or I'm on diabetes medication. And then I test them and their levels are off the roof. And they're like, oh, well, I stopped taking my medication because I checked the last time and it was fine. And I tell them, well, the reason why it was fine is because your medication was working. You don't just take it like when you have a headache and you take something for the headache. You take this continuously to prevent something else from happening. So those events happen several times a year, and it's all throughout the whole nation. We get patients nonstop. We usually check those levels. We explain to them what they mean. If they need service or they need referrals, we recommend that. We teach them how to, improve their diets, things that they can modify at home. We also do other things to help them out, like check out their immunization gaps. Again, heavily focused on not just flu or the COVID or pneumonia or shingles, but at other vaccines that can prevent cancer, like the HPV or hepatitis B, because a lot of the other cancers that impacts our communities are liver cancers. And a lot of them are due to hepatitis B exposure, and if they don't get vaccinated, then they will be exposed to that.
Thank you. Eva, let's talk a little bit about that too, kind of some of the diseases that can lead to cancer. H. pylori, that's another one. You know, those are all treatable. But I want you to kind of walk through some of the stages. I don't think everyone is 100% aware of what it means to be stage 3, stage 4, and why it's so important to catch things early. Because once you start heading up that, what does that mean to some people? You know, unless you've experienced cancer or someone in your family, then you start kind of knowing what that all means. But walk us through from like some of the basic things that we can do for prevention and kind of leading up to.
Yeah, excellent. Thank you. So the cancer is classified in different stages, generally 0, 1, 2, 3, or 4. And if it's classified correctly, then the physicians will know exactly what kind of treatment is best for you. Sometimes it's misclassified, and so it takes a while to get the correct diagnosis sometimes. Basically, for breast cancer, for instance, even before you feel a lump, the mammogram can often find little white speckles that are arranged in a suspicious way that the radiology doctor says, this looks suspicious, and they call it calcifications. Well, they can't even give me a size of a tumor or a lump. The woman cannot feel anything in the breast. The doctor cannot feel anything, but yet it shows up on the mammogram as suspicious calcifications. In most cases, if that's done with a core biopsy, a biopsy proceeds and is found with an early stage breast cancer. Many times we're talking about stage 0 breast cancer. It's only in the milk duct where those little calcifications are. It could be 2 years, 5 years before the woman would feel a lump, depending on her age and the type of the cancer. But if we find it at a stage 0, it's localized in the breast tissue, sometimes inside one milk duct only, and it's before it has progressed. If we don't find it at stage 0, then it will continue to grow. By definition, cancer is nothing more than an abnormal multiplication of the cells. So once that process starts, it takes treatment to stop the process. Otherwise, it's like an army slowly moving through your body and taking over. If we don't find those calcifications on a mammogram, then maybe 2 years, 4 years later, the woman will start to feel a lump in the breast. And then the mammogram and ultrasound, if we biopsy it at that stage, it still could be treatable. But then the question is, has it advanced into the lymph nodes or not? When we talk about classifying cancers by stages, usually the stage is based on the size of the tumor. Whenever we diagnose it, is it 2 centimeters, 4 centimeters, 5 centimeter size? The staging is also based on the status of the glands or the lymph nodes. So the breast cancer, the first place it will start to spread to is to the axillary glands underneath your arm. So if a right breast cancer is infiltrating, invasive cancer, the first place it tries to get to is to the lymph nodes or glands in the axillary armpit. And so we need to know if it has already reached that or not. So that also determines the stage of the cancer, how many lymph nodes might be involved. If we still don't catch the cancer and it continues to grow, your as a clinician and even the patient is able to start to feel lumps underneath your axillary armpit. So it's an enlarged lymph node if we still have not caught the cancer and started the treatment. And of course, those women then that know it's cancer and on occasion refuse treatment, that's where you can actually feel large masses under their axillary armpit. Once it gets into the axillary lymph nodes, even if it's microscopically in the lymph nodes on the day of surgery, then that means live cancer cells are now floating throughout your body through the lymphatic system, and it just takes a matter of time then until they build up enough strength to break into dangerous places like the lungs or the liver, create those same tumors that are now in the breast tissue will start to grow if the cancer cells break into the lungs or liver, and that's where we talk about a stage 4 cancer. The cancer that started in the one milk duct in the breast is now circulating throughout the body, and now we're able to see those same kinds of lumps or tumors in distant parts of the body where it started. That would be a stage 4 metastatic cancer. We can still treat it, we can put a pin in it, or we can stop it from growing and multiplying and growing fast, but we cannot treat for cure at that stage. We cannot remove the cancer cells from your body if it's a stage 4. We have excellent treatments for breast cancer, stage 1, 2, and 3. We're talking about treating for cure in most cases. Removing the cancer so that it's no longer in your body. You're cancer-free. Of course, a stage 4 is not able to treat for cure. We're able to treat for palliation or for comfort and to give you the best quality of life as possible. But I tell women all the time, I'm so happy you did that mammogram 3 months ago. That's what found this cancer at stage 0 or stage 1. And now we're moving into the treatment phase when we're really talking about excellent treatments. There's so much fear involved. I mean, and when you're talking about barriers, I was sitting here thinking about our elders, our grandparents kind of grew up where you didn't go to the doctor unless you were sick, right? I feel fine. Why am I going to the doctor? Where clearly the message these days is that doctors help you stay healthy and well and keep and maintain health. And that's a paradigm shift that most of the young generation now can accept, that doctors can be partners with me in staying healthy and staying well. And again, using the preventative exams that are available for the purposes of finding diseases early. But once the disease is already found in your body, then it's a matter of putting together your treatment team and working with your treatment team to treat it and to still maintain the best quality of life as possible. Usually we think of cancer in particular as an old woman's disease, as an older person's disease, and in the past that was true. That's no longer true, just from the testimony of Michelle tonight. I've been doing breast care for a long time. My youngest breast cancer patient here at White Memorial was diagnosed with full-blown breast cancer at age 22. And that was a mystery to everybody. But then, of course, she went to multiple clinics here in Los Angeles County. She finally crossed the border and came back. By the time she got to me, she walks in with a report in her hand from Tijuana, says atypical cells. And that's the best they could do. But that was good enough for us to then proceed with the ultrasounds and biopsies, and we were able to diagnose a stage 3 cancer. In her case, she had the BRCA1 and BRCA2 gene, and that's why she got the cancer, was so aggressive, and she got it so young at age 22. Her grandmother had ovarian cancer and was a survivor and was never tested. Her mother had ovarian cancer and was a survivor and never tested. And so now the young lady at age 22 was positive for BRCA1 and BRCA2, and that was what contributed to her aggressive breast cancer. So now there's so many new things coming available to us. It's a matter of empowering people with information and with education. If I'm going to carry that, we want to identify the families that carry BRCA1 and BRCA2 gene, even before they get affected with breast cancer, if possible, because we can do lots of things related to prevention. Right. And close surveillance, or again, prevention of the breast cancer.
Perfect segue, because I was going to lead to that conversation about how in our community, we don't talk about the past and the history. And, you know, my wife's grandmother, I remember we were asking her, when she was alive, we were asking her if she remembered how her mother died, because we thought that there might be some kind of either cervical cancer or breast cancer. And she just would tap dance around that and just didn't want to say it. Oh, she died of something. Algo le dio, you know. Tenía un tumor, pero no se sabe. You know, there was. And so it's so important. How do we deal with that? How do we deal with that cross-generational conversation that needs to happen with grandparents being able to tell us, again, grandparents that didn't go to the doctor unless they were very sick or didn't go to the doctor at all. How do you guys, maybe Dr. Flores, Dr. Nevares, maybe you can tell me a little bit about what you guys experience with that and how we can solve that problem.
Yeah, part of it is dedicating time to the patient, right? So again, the design of medical practice today, the assembly line thing doesn't work. And that doesn't work for anybody. So you have to be able to have control of your practice to structure it so that you're actually dedicating that time to the patient. Because you have to develop a relationship and basically diagnose their frame of reference about health and what they're willing to share and what they're willing to explore and ask others about for their own health and their family's health. So, for example, a common thing is exactly what you're describing, right? They really don't want to know, and so they never really inquired. So part of that is asking them and engaging them in a conversation to say, okay, you're from the old country, you're resistant to calling your family members. but do this for your children and your grandchildren. And then when you put it in that context, they realize they're making an investment, not in themselves, which might be perceived as selfish, but they're doing it for the youngsters in the family. So that becomes a motivator. The other, we see this often with diabetes or some other chronic condition where they go, Dios me dio esta enfermedad, Dios la va a curar. God gave me this disease, God will take care of it. I said, no, God put me here to work with you to actually help you get better, right? So you have to kind of learn how to, sort of the levers you need to pull to engage the patient in that conversation.
Here at White Memorial, every woman that comes into our mammogram suite for a routine mammogram, regardless of their insurance, is screened. And that means for hereditary cancer genes. That means they're handed an iPad or asked to do like 6 questions on the iPad that helps us identify women that are eligible for genetic testing. So, how many people in your family have breast cancer? What ages did they have breast cancer? So based on national guidelines all around the country, people are eligible for hereditary genetic testing the genes you were born with. You got 50% from your mother, 50% from your father. There's national guidelines if you're eligible for cancer hereditary genetic testing. And the red flag for women, especially who carry those genes, those high-risk genes, are multiple cancers in the family, young cancers in the family. So anybody under 30, under 50 diagnosed in your family with cancer would be a red flag. And the third one is rare cancers. Any pancreatic cancer, ovarian cancer, any man with breast cancer would be considered a rare cancer. If those are in your family history, you're eligible for genetic testing. And to put it in perspective, those women found with the BRCA1, families found with the BRCA1, BRCA2 gene, we already know science tells us that they have 87% chance risk of getting breast cancer by age 70. So, 1 in 8 women get breast cancer in the general population. But if I carry the BRCA1, BRCA2 gene, I have 87% chance risk of breast cancer and over 60% risk of ovarian cancer, which is usually considered a rare cancer. To put it in perspective, out of all the people that get breast cancer, only 10% of them carry the gene, but I need to know who those 10% are, because those are the ones that are really high risk. And we're really trying to spread this program out into the primary care doctors' offices, our GYN office here at White Memorial. We're trying to get it into AltaMed and be able to get the basic screening tool out to the community population. Once women know that they have that BRCA1 or BRCA2 gene in their family, then it's a matter of empowering them to share that with their brothers. 50% of their siblings and children and first cousins would have the exact same gene, and we always call upon the Angelina Jolie case then, where she grew up with all of her relatives and aunties and grandmothers and cousins. Everybody knew that there's lots of breast cancer in our family. When she found out she had the BRCA gene, she was able to remove the breast tissue with surgery, pop in an implant. You wear the same kind of clothes, but she just reduced her chance of breast cancer from 87% chance risk to less than 1% risk just by removing the breast tissue with surgery. And that's an option for our women here in the community, even before they are affected with cancer, if they're willing to do if they qualify and are eligible and are willing to do the genetic testing, which is a simple saliva. You spit in this little tube, send it off to the genetics lab. We're not talking about 23andMe. We're talking about medical grade genetics. But once the BRCA1 and BRCA2 gene have been found, and then they're eligible for closer surveillance with breast MRIs or surgical intervention to reduce your risk. If I don't have any breast tissue left, if I remove the mammary gland, I'm not going to get breast cancer in most cases. And that's options for women these days who are able to identify those high-risk cases.
Great, thank you, Eva. So at this point, let me open this up let's have a diálogo. So let's see if anyone here, are there any questions in the audience? Anybody that wants to take the mic? I always go to my reporters.
From many of the conversations that I heard tonight, I think it all just leads to, I think a lot of the work that has to do with our community is just educating a lot. How can, even as reporters, providers, or even the community, how can we get to the point of just educating more about the chronic illnesses, the mental illnesses, and more?
Social media is a great avenue for the younger generation that use it. It's these days, patients come in, right, already knowing what their treatment is and knowing what potential diseases these symptoms apply to. And that's a matter of education, but a good quality education. Go ahead.
Dr.
Yeah,
Navarez.
I like to do storytelling. And I think bringing up storytelling about specific patients, specific people that you know, and I'm really impressed how much you can just get on Google and ask the questions. You know, in fact, the statistics change all the time. So one of the things I did a couple of days was, what is the leading cause of death in the U.S.? What is it in women? And you know what? The answer pops right up. Do you know how much time I spent in the library trying to find that vital statistics? And they were usually like 10 years behind. So yes, the stuff is out there, but write some good stories. Write some, you know, I know there's HIPAA and you have to be careful, but I think, Hector, you probably have some patience. I know you have patience, and you can write good stories.
Michelle's story.
Yeah.
So many stories.
Michelle's would be a fabulous story. That's a really, whoa. I have a question too, by the way. Do you think Walmart wants to get on board with doing nutrition counseling so that, just an idea, and we do have food deserts. Do they do Instacart? Again, is there a way we can get food delivered?
Well, I'm not sure about the details, but I know Walmart does offer different programs for ordering groceries online. And now they're doing different programs where they're merging different sections of, you know, let's say pharmacy in other states where you can order your groceries and you can have your medication delivered to your house. That can be very beneficial for working parents, you know, for people that are ill, for elderly. They don't have to go figure out how to go to the grocery store. They can order from their phone, from their computer, or somebody can do so for them, and then just have it delivered to them.
And if I could add just to the question, because it's a great question, how do we educate the community? So social media definitely, you know, print media and radio and other mass media is still very effective, especially for the older folks in our community, right? You've all heard that the top 12 radio stations in LA County are all Spanish language stations, right? So there's power in those media that we can use to get the word out. The other piece is what we learned through the pandemic, the COVID pandemic, is how to mobilize entire communities, working networks with community-based organizations that have enclaves or neighborhood influence that we could not possibly get to in an efficient amount of time. And that's where the media was very helpful to us, to be able to get the message out there and the information and to get feedback on what we were providing. So I think there is a lot of infrastructure that we just need to activate again to make that happen.
Great, thank you. Anyone else? Yes.
Hi, I'm Brenda, and I actually confided with Martin a couple of weeks ago. My mom has been feeling a lot of like pain and just hot around her breasts. And I had a question. How much do we as family advocate for our family that doesn't feel like we're pushing it onto the doctor? Because sometimes I'm like, can my mom actually have this test? Like even if you don't think she need it, can she still get it? So is there any tips around, advocating for your family in a way that's still respectful to doctors?
I told this story a couple of days ago, and I hadn't thought about it for a long time. But my mom was in the intensive care unit because they thought maybe she had had a heart attack, but they weren't sure. After all the tests came back, they were sending her home without a catheterization. And I was sitting there, and I knew something was wrong, just like you know something's going on with your mom. So I said, could I talk to the cardiologist? And yes, I am a doctor. It does make a little bit of a difference, but you can do this too. And you talk to the cardiologist and you say, I think something else is going wrong. You don't want to be too pushy because then they assume you're just crazy, which I worry about that, especially because I'm a doctor. But I sat there and I watched my mother going, no, I don't feel anything. and she's rubbing her chest. Like, I know something's going on. So I said, do you feel anything? She goes, no. So I turned around and translated, yes, she feels pressure. She feels really bad pressure. The point is, you are translating for your mom. Now, this heat that she's feeling, maybe it's nothing. Maybe it's, depending on her age, what it is. But you need an answer. And yes, it is totally fair game to go in and push for the answers. She did get cath. She had really horrible posterior MI, 5-vessel bypass. It was such a mess, and I was so grateful she went home. But if I hadn't have lied a little bit, translation is what I call it, she would have been sent home. She'd have died that night.
And yeah, I think those stories are really important, and the advocacy should never be underestimated, how powerful and important it is. And that also includes asking for a second opinion, right? Again, as Latinos, we're very respectful of the profession of physician. You know, it's priests, teachers, and doctors, right?
And licenciados.
And licenciados. And I even had patients that go, Dr. Flores, right? I mean, that shows the incredible respect they have for us. But, you know, getting a second opinion, I always tell the patient, you can ask for a second opinion. If the doctor gets offended, that's a clue that you probably need to change doctors. Because a doctor with a healthy ego would say, well, yeah, I would do the same thing. I would go get that second. So, the patients can be self-empowered. They can be empowered by a family member. But we also need to teach clinicians how to empower the patients to actually say, you know, you can ask me any question and I will not be offended. Yeah.
Great. Any other questions? Michelle?
Yeah, this is sort of a future-facing question, but, you know, at least in my case and in the case of many people who I know share similar stories, it took so long to get like an initial consultation or initial diagnosis. And I was wondering what your thoughts were on kind of the direction of utilizing AI to get maybe an initial confirmation of a diagnosis so that you can see a specialist quicker, because it seems to me that it's apparent that there's an oversaturation in the system, right? Really high need for medical assessments and maybe not enough physicians.
I had plenty of patients walking through my door. It was not AI, but they Googled it. They Googled everything, and they copied it and handed it to me, and do I have this, and do I have that, and do I have that, and shouldn't I go here, and shouldn't I go there? One of the things you do is you bring up good points. I mean, it's something to look at. And maybe your primary provider, whoever you're seeing, doesn't know. The other thing is the physician in the back of the mind is saying, well, if I don't pay attention to this, and they're right, I better make sure that it isn't this. So they'll order appropriate tests or refer.
Yeah, absolutely. So the promise of AI is still yet to be materialized, because to a large degree, AI is still based on work done previously and inputted into the algorithm for AI. So you can get junk in and you can get junk out, right? So that's still something we need to be aware of. But when it is properly tested and vetted and improved, it actually can be very powerful. We've actually been using AI for a generation. You know, when you go to a doctor, the older patients who go to the doctor and get an EKG, that's a machine, a computer that actually uses machine learning and artificial intelligence to begin to suggest possible diagnoses based on the tracing. So we're familiar with it, but we just need to harness it and make sure that we get it to a point where it's trustworthy, you know. And yeah, we've always joke about the internet positive patients, right, that come in with those printouts, but that makes us better. You know, and I always tell patients, please bring it in. You know, a third of it is not useful to you, a third of it is actually junk, and a third of it is useful to you, so let's figure it out together. And that makes us better because we learn in that process.
That's great. Thank you. Okay, we had one question over here. Do you have a question?
Buenas noches, en español, por favor. ¿Por qué el cáncer no se siente? ¿Por qué el cáncer no duele? ¿Por qué el cáncer lo detectan en etapa 3, 4, su final? Porque el cáncer no se puede aliviar. Mi hermano nació con un tumor canceroso, pero no se le detectó hasta los 40 años. Él tenía 47 años y no le dolía nada. Y cuando se dieron cuenta que tenía cáncer, solo duró 3 años, pero no le dolía nada. Porque los doctores no pueden aún detectar cuando viene un cáncer.
So I'll translate a little bit for anyone. So she's asking, why is that some cancers are you can't feel, they're not painful? Why is it that it takes so long for doctors to discover certain kinds of cancers? Her brother had cancer as a kid and wasn't detected until later in life. So what is that? Especially like pancreatic cancer, I'm sure you can talk about that a little bit.
Yeah, eso es la verdad con todos los cánceres. Cuando están muy pequeños es nomás otra célula, pero no hay modo de hacer el diagnóstico. Poco a poco estamos descubriendo a ciertos cánceres. De prevenir el cáncer es lo más importante, y nomás hay un cáncer que conozco yo que se puede prevenir, y ese es el cáncer del cuello de la matriz, el cervical cancer, y ese es sabemos que es virus, HPV, y una vacuna se puede dar. Pero para saber que es cáncer se tiene que sacar ese tejido, cortarlo fino, ver abajo de un microscopio. Pero no duele, y puede estar ahí por años y años y años. Y por seguro no vamos a sacar todo el tejido y ponerlo abajo del microscopio porque no queda cuerpo, ¿verdad? Y por eso, sí, depende si hay alguna bola, si sangra ese tumor, puede causar dolor. Pero la mayoría es nomás una célula. Es todo. ¿Sabe qué tipo de cáncer era?
Él es hombre, era un cáncer progresivo. Le dio en medio de los pulmones y cerca del corazón. Tenía 2 tumores, pero no le dolía nada y él nunca sintió dolor de nada. Entonces nunca se lo detectaron hasta la etapa ya final.
Sí, es algo muy difícil, como dijo la doctora Nevares, que es muy difícil en muchos casos detectarlo temprano. No tenemos todavía la tecnología para hacerlo. Y también es importante saber que no siempre dolor se presenta en un cáncer. Puede ser un cáncer como en el caso de su hermano. Entonces, todo tiene que ver con consulta con un doctor de cabecera que lo llega a conocer al paciente, y se empiezan a notar algo diferente, por lo menos ya empiezan a sospechar. Quizás a este paciente sí le tengo que hacer un MRI o un CAT scan para detectar un cáncer que no se ha presentado con las síntomas clásicas de dolor o sangrar o lo que sea. Así que no tenemos todavía la tecnología. Hay mucha promesa en pruebas de sangre que le dicen liquid biopsy, biopsias líquidas, porque podemos sacar sangre y detectar con el ADN, el DNA o ARN, detectar cánceres más temprano cuando el paciente no sienta los síntomas. Es una tecnología que está empezando a este momento. Oímos de la gene del cáncer de los senos, que ya existe la prueba, se puede hacer, pero hay muchas que todavía se tienen que desarrollar. Lamentablemente, no siempre se sienten síntomas hasta que ya es un poco tarde.
Great, thank you.
So the answer was just basically that, the patient may not have symptoms because cancer doesn't always show up with pain or some classic symptom. Usually by the time the symptoms show up, it's pretty advanced.
Are there, when you do blood work and you do certain kind of blood work, is there hormones and things like that you can identify that there possibly might be some growth?
Very specific cancers.
Very specific cancers.
Yeah.
Okay. Thank you. Any other questions? I don't want to keep you guys too long. I know that there's a lot of things going on tonight at other events. I know I don't want to make light, but the Dodgers are up 5-2 in the bottom of the 4th.
All right.
Those of you who are here and not watching your phone, thank you. Thank you all for coming. Thank you all for participating. Thank you for the panelists.
Thank you for inviting us.
And please enjoy some of the food we have there for you, some fruit and some beverages. And again, thank you all for attending the Diálogo, sponsored by the Latino Media Collaborative and Calo News. Thank you.